Okay, we're back. So there's a lot to know about COVID, especially if you're taking a microbiology class and people might ask you questions. Who knows? So here we are looking at COVID-19 treatment and prevention. Okay, cool. So let's move on. A study recently came out that looks, well, no, this is not a new study, but basically China published a lot of data about patients in Wuhan when the pandemic first started, and the CDC and others have been able to analyze this data and really come up with good estimates for what happens when people don't know what it is and they get basic medical care. So first, CDC estimates that up to half of transmission of COVID comes from asymptomatic people. That right there is why we could never contain this virus. That's why none of the precautions we would take with SARS work with COVID. If you set up temperature checking stations at an airport, lots of people who had COVID could walk right through, or I shouldn't say they had COVID, they were infected by the SARS-CoV-2 virus and capable of spreading it, and they would walk right through. They didn't know it, no one else could know it, unless they got a blood test, right? So, or a spit test or some kind of high-tech test. So, something like 40% of people who have it don't get any symptoms at all, right? These are the people who don't know they have it. These are the people who spread a lot of cases because they don't realize they have a disease they can spread. So they're not necessarily taking the precautions a person with symptoms would take, and no one's avoiding them because they're not coughing and they don't look sick. So this number, this is a rough number. We don't have perfect data about this. Someday we will, but this is the best number we have right now. And so we use this number with the Chinese data to do the calculations. So the numbers I'm going to give you down here are based on 40% of infections having no symptoms, and then the other 60% get broken down here. If this number was different, all these numbers would have to adjust to make up the other percentage of symptomatic infections. So let's look at it. So if we assume 40% were asymptomatic, something like half were mild cases, this would be like getting the flu. This would be like having a really miserable week. When you have pain and malaise and a fever and you just feel terrible, but then you get over it. Something like 7% were severe cases, and so these people would have difficulty breathing, and they'd be getting fairly low oxygenation of their blood. A lot of these other things, I don't know what they mean. I'm not a clinician. I don't know what lung infiltrates are, and I don't care. So 7% were like that, 5% roughly were critical, and so these are people who would have died without intensive care. So they had respiratory failure, or they went into shock, or they had multiple organ failure. And then 2.5% died. Again, if this number changes, if the asymptomatic number changes, all of these would adjust a little bit to make up the other 60% roughly, or the other percentage, whatever that would be. And here's where you can find these data with more discussion of it. So a recent paper came out in May 2021 where they looked at people in the US and they gave them basically an antibody test to see if they had ever had COVID, and then they looked at their medical records. And so these are people who had COVID in late 2020. So for every positive test, there were probably 2 more people were infected. And so if this is true, then there have been 90 million people in the US who have had COVID. We just don't, it's hard to extrapolate numbers like that. But based on this, something like 2% of people had to be hospitalized. 2% of people with infections had to be hospitalized. And of the symptomatic cases, of the something like 60% of cases that had symptoms, 1% of them were fatal. And so these numbers are a lot better than the numbers, the Chinese data. And that's partly because this was a year later and lots of people had experienced treating COVID by then. And so we fully expected better outcomes from hospitalized patients in November 2020. We expect that to be much better than March 2020 or December 2019. And again, here's a link to the article and all the information you would need to look it up if you wanted to. If you're not sure how to find articles, but you want to, go to a library and show one of the librarians this information, and they'll be able to find the article for you. Okay, what I'm interested in are the long-term effects of COVID, because I've read news articles about people who have lingering effects of COVID. And so I want to get you numbers. And recently, several papers have come out where people have studied this in different ways. So the first was a very small study at a German outpatient clinic where they were able to contact young adults who had had COVID and had been to that clinic for treatment. They contacted them and had them answer questions on the phone. So they gave them a systematic telephone interview that is able to test their cognitive neurological function, and it's a basic psychiatric screening. And so what they found was almost 80% of the patients had mild cognitive problems, like short-term memory problems, attention problems, concentration problems. They also randomly selected age-matched other adults who had not had COVID, just to show that those people generally do not have any of these conditions. But they didn't have enough people in their study to really draw any conclusions beyond this, and they weren't trying to. The case is different in this huge study where a very active research group, they have access to a large network of electronic medical records. So there's a big project where groups will take medical records and anonymize them. So they're able to use them for research purposes without violating the privacy laws. And so this is a research group that used that database. So they had something like 8 million patient records. And they were looking for patients who had survived inpatient treatment for COVID-19. These are mostly American patients. And for each patient, they identified a demographically matched patient who had not had COVID-19. So they're able to do things like compare COVID to influenza. So they were able to match patients with COVID to patients who had influenza and see what the different long-term effects were. And they also looked at the severity of COVID. So they wanted to know, does the severity of COVID itself predict the long-term effects of COVID? And so the way they assessed severity was classifying all these records into the least severe, not hospitalized. More severe would be hospitalized, more severe would be admitted to the ICU, and then the most severe would be they had encephalopathy or delirium, some notable symptoms or observable signs of damage to their brain during their stay with COVID. And so we would predict people who had had obvious effects of the brain to have neurological effects long-term after COVID. So again, they did a systematic search. This is the paper. And I'll be referring to it as, I don't know how to say that, Tackett. Let's say Tackett et al. Et al. Again means et alia, it's Latin, it means like and everybody else, because there were something like 10 other authors who all worked together on this analysis. But this is the person who wrote the article. So here are some of their results. Something like 13% of them had their very first diagnosis of a neurological or psychiatric condition. So what does that mean? That means that of all these people, of the 280-something thousand people in their database, this is the fraction of them that after they got over COVID, they had some neurological or psychiatric disorder that they had never had before. And this was lower for the patients who weren't hospitalized, and it went up to something like 30% for people who had had signs of brain damage during COVID, but also for ICU patients who didn't have any brain damage. Something like a quarter of them had their first ever diagnosis of neurological disorder after COVID. And then a larger number had a recurrence of something that was already diagnosed. So a lot of different neurological and psychiatric conditions people had are exacerbated by COVID. So again, big numbers. So these are the conditions that they looked at. These are the different things people can experience 6 months after getting COVID that are caused essentially by COVID. The most common were anxiety disorders and mood disorders. So no study was made in this research about like why. They're not studying how the brain works. They're just studying the medical records, so they can't say why. But these are the most common. But there are also disorders of neuromuscular junctions and nerves and nerve plexuses. So problems of nerves, problems sleeping, stroke, and then, as you've heard in the news, psychotic disorder. People are having psychotic episodes. So these are the most common, these are the least common, but some patients would have intracranial hemorrhage or strokes after having COVID. And these they compared to people who had influenza, and they were not seeing this with influenza patients. So COVID is kind of unique in triggering all of these different things. So then, how late were these things happening? Were these diagnoses happening a week after these patients got discharged or a month after? And basically, they had all sorts of different situations, and what they're able to predict is a person's risk of diagnosis at any given day after COVID. And so, yeah, in the first 30 days after discharge, that's when the risk of getting one of these diagnoses is highest, but then it levels off and stays a constant risk for 6 months when they stop looking at the data, and it doesn't go to zero. So people are at risk of developing these conditions who knows when later. It could be, for all we know, they have this risk for the rest of their lives. We just don't know because we don't have the data yet. I'll point out Guillain-Barré syndrome. This is a well-known syndrome that happens after a lot of different viral infections that leads to muscle paralysis. And influenza can cause this, COVID can cause this, lots of other diseases can cause that. Any of these is going to severely disrupt a person's life. So this is a person who has recovered from COVID and now they have a stroke, or now they have 6 months later a problem with controlling their muscles, or they develop dementia or paralysis. That's what we're looking at here. 6 months later, people are developing these life-changing conditions, or anxiety disorders or mood disorders. So, yeah. And so these were, again, much more likely after COVID than they would be after influenza or other respiratory diseases. This is not something we knew last March. In March 2020, we didn't know about long-term effects of COVID, but we do now. And so now we know after recovering from COVID, a person is at risk of developing one of these for at least the next 6 months. So what's the effect of COVID's severity? I should point out again, all of these things are more likely in people who had severe cases. So that's not that surprising. And what we do read about in the news is people who were hospitalized, recovered, and then their life has changed forever, perhaps, by these chronic neurological conditions they develop. And that's what this next study is about. They had 200 patients who had severe to critical COVID-19 but survived. And in this study, they brought the patients back in for physical and psychiatric testing. And they showed most of them had recovered, their immune responses were back down to normal, and their lungs had healed. But of these patients who survived severe to critical COVID-19, 4 to 7 months later, more than 60% had trouble breathing. One of my friends is in this situation. He's, in his words, it hurts to breathe. Every breath he has taken for a year after getting COVID has been painful. And that would be down here, the 37% of people who had persistent pain. So just think about that. 1/3 of the people who survive these critical cases of COVID-19 have persistent pain. 2/3 of them do not regain full respiratory functions in 7 months after getting over COVID. Half of them have persistent fatigue, so half of them may not be able to go back to work. They can't do the things they used to do because they have persistent fatigue that is not relieved by things like sleeping. And something like 1/3 of them can't move around like they used to. And so every single patient they had reduced quality of life. So getting over COVID was not really getting over COVID. Getting over COVID was getting over the acute phase, and this is the chronic phase of severe to critical COVID. So this kind of thing is why I am really still angry at people who didn't like the idea of social distancing, and so they made up all these ideas about COVID being a hoax. Because people who have lifelong fatigue because of COVID don't see it as a hoax. And it's deeply irresponsible to let political views change views on science and public health. It's perfectly reasonable for a politician to say, here's what public health people are telling us, here's what scientists are telling us. We have to make a decision, and we don't have to let them decide. It's perfectly fine to say, we have to make a decision that goes against public health. But that's not what we've seen. We've seen people say they don't trust public health, or they think public health is lying because they don't like what they've said. And people experiencing these things are the ones who suffer because of that. So I'm going to wrap this up with a couple more slides. Basically, right now in the US, someone who gets COVID has a much higher chance of survival than they would have in March 2020. And that depends on the quality of their ICU care. Right now, we have great care. The US has very high level of intensive care. That evaporates if we have huge numbers of patients. So that's been the whole problem with surges. That's why people started to really pay attention to the numbers of ICU beds available. Once those available beds became really scarce, cities have to shut down because they have to stop the spread of the disease. And the social distancing is the best prevention we had before vaccines came out. And so what we saw in, Los Angeles. So what we saw was intensive care workers were overworked, and hospitals were expanding their intensive care capacity, but they didn't have extra critical care trained nurses. They didn't have extra specialist doctors. They ran out of staff who were trained to work in the ICU. So they're pulling nurses from other wards to work in the ICU. And there are cases where people were just trained in one day to go from whatever their nursing specialty was to critical care, which would normally be months of training. And so we just don't expect the best healthcare outcomes when we have untrained people dealing with those situations. And that's what we want to avoid. And so during the surges, that's what we saw. And as I'm speaking right now, India, rural India is going through something like this, where correspondents have seen people dying in hospital hallways because the demand for healthcare is so much higher than the supply. And partly this is happening because they relax their social distancing, and so they're having a much bigger surge than we have ever had. And again, I look forward to the day when enough people have been vaccinated that this doesn't happen anymore, and that people can get the health care they need when they need it. But anyway, this is why we don't want another surge. The other thing I want to point out is that in every country, non-COVID mortality has increased. And this is for a lot of reasons, some of them social, but others, people are avoiding healthcare because a hospital is a source of infection during COVID. So, yeah, it's been very bad. So 2 more COVID slides. What would have happened if we didn't use social distancing? Well, this is what lots of people were talking about back in March 2020 and February 2020. I knew some people who knew the top public health people, and they had access to the best data. And anyone could have looked at the data back then and seen that we were headed towards a catastrophe. In March 2020, in Los Angeles, for example, the cases were doubling in something like 2 to 3 days. And so within a month, it would have doubled 10 times. And 10 doublings is 1,000-fold increase. If you do that for 2 months, that's 1,000,000-fold increase. And so if that had happened unchecked, it would have been a disaster, because ICU bed demand would have gone up many times what capacity was. At the same time, all of these people would have been getting sick. And so there basically would have been no healthcare. So we would have been back seeing March 2020 levels of healthcare. And so probably something like 5 or 6 million dead in the US, and tens of millions would have had those long-term health effects. And we've avoided numbers like this, at least. And social distancing was the only way to do it. There's no other technology that existed back then to control COVID. So if we're looking back at March 2020, and this is what I want to end with, why was March 2020 so confusing? Why did we have changing guidelines? We were told things like wipe down surfaces, you don't need masks. Then we were told you need masks, and we heard it was aerosol, and we heard it was droplet. Part of the problem was that people in public health thought it was SARS. I mean, they knew it was a new virus, but they thought it was going to be like SARS, where checking people's temperatures tells you if they have it, and you could do contact tracing and quarantine and keep it under control that way. They thought it was spread by only large droplets, but COVID-19 is spread by asymptomatic people. And there's no way to know they have it without giving them a specific test for it. They don't know they have it. And so they get on a plane, they get on a bus, they walk into a crowded supermarket, and they spread COVID-19. Also, we know aerosol transmission has happened in some cases. And that didn't happen during SARS. So basically, there was never a chance of containing the virus or keeping it out of the US or keeping it out of cities. As soon as somebody had it in any city in the world, the rest of the world was kind of doomed to have to deal with it. And that's one of the reasons why I say it's a worthy adversary of humanity. The other is the long-term health effects that I've been showing you. Not many viruses find quite that many different ways to ruin a person's life as this one does. So if you can avoid it, avoid it. And then the rest of the slides, are all for your curiosity. So I'm not going to make a video about them, but they are extra information, and they're information about other conditions you might be curious about. This, for example, is the Legionella story at Lane Community College. They did find Legionella in the water supply in the summer of 2020. Should be all better by now. They dealt with it. They treated the water. They keep testing it, so they know it's not there anymore. Lots of different things you can read. Lots of different things. But if it has this up here, CUR, it's for your curiosity, and I won't test you on it. So, thank you for your attention and for letting me rant about public health and misinformation. And I hope you have some new information about COVID that you can remember and or share. And I hope you stay safe.